Welcome to Grand Rounds. My name is Gerald Wilson. I am the Director of Thoracic Surgery and the Lung Cancer Program here at Hoag. And it is my privilege today to introduce our speaker. I've been here just over 2 years, and one of the really exciting things about being a physician at Hoag is how many new physicians keep coming in with superb training and top-notch skill sets and fresh ideas, and they kind of push the level of the healthcare at our system to the highest level. And I think our speaker today is certainly in that category. I met with her and her team, and we're very lucky to have them as part of the whole family now. So Dr. Ismail is a pulmonologist who received her medical degree from the University of Alexandria in Egypt. And she did a pulmonary and critical care medicine fellowship at UC Davis Medical Center. And then she did not one, but 2 sub-fellowships, one in pulmonary hypertension and another in interventional pulmonary medicine at sort of the epicenter for interventional pulmonary in the whole world. So Heidelberg, Germany, I think the physician that heads that program is Felix Hertz. I couldn't imagine having a better mentor than him for what she does. She is currently in private practice with the Pacific Pulmonary Group, who now has an office at our Hoag campus, and will be practicing here at Hoag. She's an assistant clinical professor at UC Riverside. She's laid the foundation for lung cancer screening at UC Riverside, and she's director of the lung cancer program at Riverside Community Hospital. And I think it's worth noting that Dr. Ismail is one of 2 board-certified sub-fellowship trained interventional pulmonologists in Orange County. It's really becoming its own specialty, and I think it's one of those few specialties where there is a greater demand than there is supply. So we're very lucky that she's practicing here at Hoag. Her main areas of interest are pulmonary medicine, interventional pulmonary, and lung cancer, as well as pulmonary hypertension. And today she's going to tell us all about lung cancer screening and updates, and that's a subject near and dear to my heart because lung cancer is my area of interest as well. So please welcome Dr. Ismail.
Good afternoon, everyone, and thank you for having me here today for Grand Rounds. I think you guys can hear me very well, right? So today I'm going to talk about one of my favorite topics, which is lung cancer screening. These are my disclosure. I'm the advisory board of Gilead Science, and I work for clinical trial consultant for United Therapeutics. So the objective of the talk today is just to go over the background and rationale for lung cancer screening, the components of successful lung cancer screening program, the fundamentals, logistics, and challenges, and of course, as an interventional pulmonologist, I have to shed some light on the interventional pulmonology approaches in diagnosis and treatment for lung cancer. As we all know, lung cancer is the 3rd most common cause of cancer among women and men, and is the leading cause of cancer-related death in both genders. If you look at the left side, the right side of the screen here, the overall 5-year survival is about 15%. However, for stage 1, it can go up to 60 to 80%. Noting that 90% of the cases are attributable to smoking, and 50% of new cases are found in former smokers. These are one of my favorite graphs, actually. You can see month following treatment up to 5 years versus survival. And you can see for stage 1, we approach, at 5 years, we approach almost 50%, versus stage 4, we're almost at 0%. And despite this difference, huge difference in survival depending on the stage, yet 56% of the new cases diagnosed lung cancer are at stage 4 or distant metastasis, versus 15% are stage 1, and 22% are stage 2 and stage 3. So definitely there's a lot of work to do here in order to detect early stages of lung cancer. That prompted a lot of trials to look at reasonable screening tests for lung cancer, including chest X-ray and CAT scan. There are a lot of trials over the last 10, 15 years, but I will go through the major trials for X-ray and for CAT scan. Just a quick reminder that when we look at any screening test, we have to take in consideration that we have some screening bias, including the lead time bias, the time from diagnosis by the screening modality versus through the time actually where the cancer is diagnosed through symptoms, the length time bias, which is type of a selection bias, and finally, of course, the overdiagnosis bias. So we have to take all of these in consideration before we look in any of these trials or design any of the trials to show actually good screening tests with significant mortality benefits. One of the major tests for chest X-ray, and I have only a couple for chest X-ray. The first one is the Mayo Lung Project, which is one of the biggest projects that looked at chest X-ray and pulse sputum every 4 months versus standard care. They enrolled 9,211 participants, and they looked at stage 1 and 2 versus late stage in both groups. As you see, the results of the study just summarized in this tiny little graph here, which shows that there is no difference in mortality between the intervention and the usual care group. However, when they looked at extended time period after the project, they found out that there is some survival benefit in the intervention group versus the usual group. And that could be because of many reasons, including that maybe in the intervention group where they did the chest X-ray, they have seen some lesions or nodules that has some clinical relevance down the road after the extended follow-up. Based on this, people said that with chest X-ray, even overdiagnosis exists. Chest X-ray is not effective in reducing mortality, but this study again has its own problem. It was underpowered, and there was high contamination and compliance. That led to another bigger study looking at baseline chest X-ray for lung cancer detection in the randomized prostate, lung, colorectal, and ovarian cancer screening trial. They enrolled about 154,000 patients between the age of 55 to 74, which is pretty close to what we're doing now. These are smoker, non-smoker, with no history of cancer in the past, and randomize it to control group with no intervention versus chest X-ray. And the results showed that half of the patients diagnosed with lung cancer are at a stage 1, but yet there is no mortality benefit. So basically, everybody decided that chest X-ray is not the way to go, so looking at CAT scan now. Specifically looking at low-dose helical CAT scan, which, again, it allows the entire chest to be surveyed in a single breath hold. Takes about 7 to 15 seconds, which is pretty good. It reduces motion artifact. It has narrow slice thickness, so you can actually identify small lesion. And you can have 4 patients per hour. It's a lower radiation dose than the regular CAT scan, and I will show this in a different slide after when we talk about the downstream implications of CAT scan. So these are some of the trials that came before the big national lung screening trial, and as a matter of fact, it had led to the national lung screening trial, including the Early Lung Cancer Action Program, the Swenson trial, and the international I-ELCAP trial. Out of these, I would like to talk about the first one and the third one pretty quick. This is the Early Lung Cancer Action Program, and this is actually a very interesting study. They enrolled about 1,000 volunteers, age group between 50 and 79, smoking history, 20-pack year plus, and they randomized these patients to CAT scan versus chest X-ray. Out of the patients, 233 patients had abnormal finding for the CAT scan versus 68 patients had abnormal finding with the chest X-ray. And then out of the 233 patients that has abnormal finding with the CAT scan, only 27 patients had lung cancer. But out of these 27 patients, 23 patients did have stage 1 lung cancer. which again was a major alert that low dose can detect early stage lung cancer. That led eventually to the International Early Lung Cancer Action Project. Bigger trial, multi-institutional study, better design, a lot of patients, 31,000 patients. Unfortunately, each institution has its own selection criteria, which is, I believe, it's a major problem with this study. They said we're going to do initial screening between 1993 and until 2000, and then we're going to have repeated screening annually for these patients. The repeated screening, with the annual screening, was about 27,456, so that was a lot. At that time as well, they weren't following the recent guidelines for the pulmonary nodule, as we will talk about later. And they decided to look about the 10-year lung cancer specific survival rate in these patients, looking about how many patients had lung cancer, how many of these patients were diagnosed with stage 1, and how many of the stage 1 had actually had surgical resection. I believe it was one of the best trials published as well in the New England Journal of Medicine. So they were able to identify 412 patients that had clinical stage 1 lung cancer. Among these, 302 patients had surgical resection within 1 month with a survival rate of 92%. And there was 8 participants with clinical stage 1 who did not receive treatment and died within 5 years after diagnosis. This is Kaplan-Meier curve that looks at the survival for all lung cancer detected by the study versus resected and only resected clinical stage 1 lung cancer. And you can see the difference, 80% versus 92%. So, lesson learned from all these CT trials, prevalence rate varies from 0.4 to 2.7. However, age and back year smoking history are a very strong predictor of lung cancer. The nodule detection rate was variable as well between 5 and 51, which is a huge range. And that depends, of course, on the definition. What do you mean by nodule? What do you mean by abnormal findings? What is your slice thickness? What's a benign nodules? And then definitely CT results has more than threefold higher detection rate versus chest X-ray. All of this led to a downstream implication as well of CT screening. Okay, what's the radiation carcinogenesis? Am I going to get cancer by these annual CT scans or every 3 or 6 months CAT scan? A question that we still have a lot of our patients ask until this day. We had minimally invasive procedure, percutaneous biopsy, bronchoscopy, even VATS. Were these acceptable? Is it acceptable really to have thoracotomy for benign disease? And if it is, what's the acceptable percentage? What's the post-operative mortality and morbidity out of this? So all of these had come after these trials. There's a high rate of false positive, as you can tell, and screening of 90 million current and past use smoker will yield more than 150 million indeterminate nodules, which is a huge number of nodules that we don't know what to do with. Addressing one of the problems with radiation exposure, and I have this in my clinic and I always show it to my patient to compare the full dose CAT scan versus CT low dose versus chest X-ray. And we tell them when we do the low dose, there's 80% reduction on the radiation you're exposed to. And we compare it to the chest X-ray, and I always like to compare it with the background radiation as well. The CT findings, definitions of term, all of these studies, we were able to detect a lot of abnormal lesions. I apologize, I can't see the ground glass, but there's something here, ground glass nodule. So a lot of new terms and definitions came. What's a ground glass? What's a part solid? And what's a solid nodule? And each one of these has its own approach when found on the CAT scan. Comes the big study, the New England Journal of Medicine study, which made a big noise, and after which a lot of lung cancer program had launched. Very well-designed study. And I'm sure a lot of you have heard about this study, and it's been discussed multiple times. So I'm just going to few points about the National Lung Screening Trial. It was designed to determine the effect of lung cancer mortality using the low-dose CAT scan. It was powered, 90% power with an alpha 5 to detect 20% difference in mortality. They wanted to look at if there is any stage shift as well in diagnosis. What are the adverse events, and what's the ratio between risk and benefits during this study? Primary endpoint and secondary endpoint set. Primary endpoint, not survival, but lung cancer mortality. And secondary endpoints, all-cause mortality, incidence of lung cancer, stage distribution as well. As I said, very well-designed study, over 53,000 patients, high-risk subject between 55, 74, 30-pack year smoking history, randomized between CT arm and chest X-ray. If you have the CT or the chest X-ray and it's normal, then you get 3 annual screen at year 1, year 2, and year 3. These are the interim analysis, starts at 2002 and ended by 2010. There was no significant difference or statistical significant difference in the patient's demographic. As you can tell, gender, education, smoking, pretty much similar in both groups. They defined what's a negative screen and what's a positive screen. And this was among all the sites that participated in this study, and they all followed the same protocol. Not only this, but if you do have an abnormal findings with a nodule 4 to 10 millimeter in diameter, for example, then you follow this algorithm for follow-up, if there is any growth versus minimal growth versus significant growth. And I believe this is actually a major, major, major point in this study. If you have nodules more than 10 millimeters, then you have to do something. Either you do a biopsy, or dynamic contrast enhanced CAT scan, PET, or repeat the low dose at 3 to 4 months. And all the institutions I mentioned, all the sites have actually followed this protocol. Results, as I said, we're aware. If you look at the year since randomization versus the cumulative number of lung cancer deaths, clearly there is difference between the chest X-ray arm versus the low dose CTs, and there was 20% relative reduction in lung cancer mortality in the low dose CAT scan. Overall reduction, our reduction in all-cause mortality was about 6.7%. Yet we had a lot of problems with this study. Before going there, just want to show you guys the stage shift, which was again very impressive. If you look at the low dose CT scan with the total patients involved with 11 and 60 versus 940. And if you look at the percentage of patients diagnosed with clinical stage 1 in the low dose was about 50%. Percentage of patients diagnosed with stage 4 in chest X-ray was 49%. So this is a huge stage shifting. But here comes the problems. 24.2% of the screens were positive. And out of these 24.2, 96.4 were false positive, and only 3.6% were true positive. So the question is, how can we capture the 3.6% without have to go through this entire 96.4% without having to do any invasive procedure that might be unnecessary with its own complications? 92% of these positive screen had a diagnostic evaluation, either by imaging or by continuous needle biopsy, transbronchial biopsy, or surgery, so a total of 84.4%. They had 16 deaths within 60 days. Out of these 16 deaths, 6 patients had actually benign pathology. So it's a problem. It's a main problem. It's a major problem, and we had to address it, and we have to deal with it. So after the National Lung Screening Trial launched, a lot of people, you can see these are billboards actually from Canada. CT scan, think it is as a mammogram for the lungs. And this one is pretty funny. Imagine if a fully loaded 777 fell out of the sky every day. That's how many people die daily for lung cancer. I don't know how they made this up. I'm really curious about this one. But anyway, so people start talking about the low-dose CT scan. You started having patients coming in. They would like to have the low-dose CT scan. They're different age group, 40, 38, up to 80. 10-pack year smoking history up to more than 30-pack year smoking history, and initially it was a major problem. That prompted these all associations, including American Lung Association, American Association of Thoracic Surgery, the European Lung Foundation. All of these decided to have their own guidelines about which patient to qualify for the low-dose CAT scan. This is the NCCN guidelines. I really don't follow these guidelines, but it came again after the National Lung Screening Trial. It's different from the National Lung Screening Trial, where it has wider range of patients to screen. But the ACCP Guidelines, the American College of Chest Physicians 2013, was very consistent with what the National Lung Screening Trial, and that's what we follow, and that's what the MCMS as well had approved later. Age between 55 to 74, smoking at least 30 pack per year, current or former smoking. If you're a former smoker, you have to be quit within 15 years. If you don't fit these 3 criteria, then you don't not qualify for lung cancer screening program. Then a lot of other, as I said, we talked about the National Comprehensive Cancer Network, the U.S. Preventive Services Task Force, and finally the CMS criteria, which again is very consistent with the National Lung Screening Trial criteria and the American College of Chest Physician criteria as well. Not only this, because of this huge difference or reduction in mortality with low-dose CAT scan, not only the CMS came with these guidelines, but they actually came with additional requirement for lung cancer screening. Meaning is, not everyone can go and do a lung cancer screening. Not every physician can do a lung cancer screening. It has to be in a specialized centers with appropriate expertise, equipment, radiology imaging. These data must be collected to a CMS-approved national registry, whether it's the ACR or the I-ELCAP or anything else that's going to come in the future. Not only this, but there was additional requirement. The CMS approved 3 visits for lung cancer screening. First visit, where you sit down with the patient and you have shared decision-making visit. You explain to him what the eligibility criteria, why does he meet the criteria. If it's negative, it doesn't mean he's good to go and he's going to survive without lung cancer. He has to come back and do an annual CAT scan. And if it's positive, we will have to deal with it according to what we find after that. In addition to this, they have required a smoking cessation program as well, and counseling about smoking cessation for patients who continues to smoke. So clearly, these are the requirements by the CMS for the low dose or for lung cancer screening. So as I said, it's not as simple as some people say, go to the office, go to your physicians, order a CAT scan. If it's negative, you're good to go. If it's positive, it gets met somewhere. It has to be in institutions where they have a lung cancer screening program with multidisciplinary approach, as we're going to talk about. Not only this, after this, there's different algorithm that came for evaluation of solid nodules, and most of us do follow these. What to do with the solid nodules? It's a medical liability if you have a solid nodules and you don't follow up, depending on what you have. If it's less than 8 millimeters, there is no questions what we do about it, depending on the Fleischner criteria or the ACCP guideline. But if it's more than 8 millimeter in diameter, then we have to assess for pretest probability of the lung cancer. And there is a lot of formula that you can Hoag these numbers and see what the pretest probability for lung cancer. The one we use at our institution is the Mayo Clinic Solitary Pulmonary Nodule Malignancy Risk Calculator. And that helps a lot when you counsel the patient. So for example, I had a 65 years old. He's a current smoker. He was found to have a 15 millimeter nodule in his right upper lobe, and it was spiculated. So after logging these numbers, his malignancy probability is 56.01%. So that tells me, even when I go talk to that patient and he's resistant to any intervention, look, your probability of this is being cancer is over 50%. We have to do something about it. It's not a wait and watch. Either we biopsy or we take you directly to surgery and just take it out and see what's going on in there. And if it's cancer, we do a lobectomy. We have to do something about it. And unfortunately, not a lot of practices have been using these modules or to evaluate for pulmonary nodules, which I think it's a major problem. Having a patient with lung nodule, as I said, is a huge medical liability, and we have to have more attention toward these patients. Not only this, new guidelines came, or not actually new, but how to follow up on the ground glass and subsolid nodules. Subsolid nodules are very tricky. Most of the time they represent microinvasive adenocarcinomas, so we always pay attention to this one. After this, a lot of papers came out about, after the CMS guideline, the CMS criteria, more centers started developing this lung cancer program. So now we're focusing more about the quality of the lung cancer program, how we can improve it. So this one of them from CHEST, looking about the component necessary for high quality lung cancer screening. It's actually a very good article. It highlights 9 essential components of lung cancer screening, and within these, they address 21 policy statements to be developed in order to assist for qualification of the program as a screening facility. I'm not going to mention all of these 21 policy statements, but these are some examples about it. Smoking cessation program's major part of lung cancer screening program. Simply, there's a lot of reasons, but I like this one. It's just the right thing to do. Another statement from the American Thoracic Society about how to implement a low-dose screening program in your clinical practice. And this article actually is pretty good, came up recently, and it addresses 3 major steps. You have your planning phase, go outside, educate the primary care, educate the community, educate the patients, lay your foundation, then go ahead and implement it, do a lung cancer clinic, how is the CT performed, talk to your radiologist. Once you develop this, you have to develop your pulmonary nodule clinic and follow up of all these abnormal findings. And then definitely, third phase is the maintenance phase, which is the quality metrics and maintenance and improvement. Very good article. This is one of my favorite slides, because it simply highlights that lung cancer screening is not a one-person job. As you can see, it's different multidisciplinary approach. They're all equal. The rules, equal rules for lung cancer screening program, starting from the local referring physicians into our lung cancer navigator, which I apologize, I did not include it here, but it's like major part. Screening these patients, sending to the surgeon, medical radiation oncologist, definitely cannot ignore the radiologist, and the most important part as well, one of the important points, is the smoking cessation program. So it's clearly a teamwork. After all of this, a lot of people came out and said, is it really worth it to do a low-dose CAT scan? What's the quality assisted life per year? Are we really saving money, or are we spending a lot of money? What if the patient needs a CAT scan every 3 to 6 months? Isn't this a lot? So this is another study that came in New England Journal of Medicine, 2004, 3 years after the initial article, looking about the cost effectiveness of CT screening in the National Lung Cancer Screening Trial. And they looked at 3 different groups. What we're going to do if we have screening with low dose, what if we have screening only with chest X-ray, and what if we don't have any screening? And it detected that the low dose cost about $81,000 per quality assisted life per year gained. And this is actually a pretty good number, because prior to the National Lung Screening Trial, it ranged between $116,000 to $3.2 million per quality assisted life per year. Not only this, they compared this number with mammogram. So they looked at all digital mammograms and the numbers, and they found about more than $300,000 per quality assisted life per year gained. So definitely, it's worth doing it, and it's cost effective. Not only this, they looked at implementing a smoking cessation program in the lung cancer screening clinic. And they looked again at the quality assisted life per year, and this is just to highlight that in all these scenarios where you have light smoking cessation intervention, or you have intensive smoking cessation intervention, that your saving per quality assisted life per year doubled, at least double, if you compare it only with the low-dose lung cancer screening without any smoking cessation intervention. So again, smoking cessation is very cost-effective in the lung cancer screening program. This is just to address all the issues, financial issues that comes with the low-dose CT scan. So what are the challenges we have right now? We need to have protocols for these scans. We have to build clinics for lung cancer screening. Some of the insurers are a little bit slow to get on the point, but we've been doing good with that. We have to have a standardized reporting system. This is not a problem here, access for uninsured and underinsured. I don't believe it's a problem at Hoag. And then the referring providers, how to assess for appropriate referrals for screening, and then how you follow up after the initial screening study. In our institutions, whether we are working right now at Riverside, or whether when we are at UCI, or even when we were up in Davis, all of these patients are basically, how do I say it, registered in one clinic, which is the lung cancer screening clinic. So if the patient qualifies for lung cancer, it goes to the lung cancer screening clinic. If the patient have a positive finding, it stays within the lung cancer screening in the pulmonary nodule clinics to follow up with this patient, whether he needs biopsy, follow-up, surgery. What's next? We need to improve the existing screening and diagnostic modalities, and we have to have safer practice, more of these non-invasive prediction models like the Mayo Clinic, for example. More about biomarkers, but this is a totally different talk that I'm not going to go into right now. How to get your institution to buy in, and we got our institution to buy into having a lung cancer screening clinic and a lung cancer screening program. It's a multidisciplinary approach, but as well you have to go outside, teach conferences, grand rounds, community outreach, even electronic alerts and reminder and EMR as well would be helpful. Back to my favorite slide, and just to talk a little bit about the thoracic surgery and interventional pulmonology. So this is a statement from the Society of Thoracic Surgeon Task Force recommendations. Actually, a very good paper that came with multiple recommendations for the role of thoracic surgery in the lung cancer screening program. And one of these are CT screening program should have a ready access to minimally invasive diagnostic therapeutic procedures and minimally invasive thoracic surgery. In other words, is not every place can have a lung cancer screening program if you're not able to have or to provide minimally invasive thoracic surgery. Strongly encourage the use of this minimally invasive thoracic surgery, including both video-assisted thoracoscopic and robotic approaches whenever available and feasible. Unfortunately, we have a very busy program, but we don't have a surgeon that can do a robotic surgery. This is a fight. Here's a thoracic surgeon, and here's a radiation oncologist fighting over stage 1 lung cancer. And we almost have this fight every other tumor board meeting where we have stage 1 lung cancer and patients referred to surgeon versus the radiation oncologist talking about stereotactic radiation and cyberknife. A lot of trials since the Japanese trial came out. I'm not going to go into this debate. I just let them fight and watch them. But overall, simply, if it's stage 1, take it out. And if it's inoperable, just we can refer the patient to cyberknife. These are my 2 cents on this topic. The role of interventional pulmonologists, as I said, I'm sorry, but I have just to say a few things about this. We have the American Association of Bronchology and Interventional Pulmonology, and then the World Association of Bronchology and Interventional Pulmonology came with different statements regarding the role of the interventional pulmonologist in the diagnosis and treatment of lung cancer. It's definitely an evolving role. In the past, we used to be perceived as patients basically come to us when they're terminal stage, but right now, our rules is more diagnostic and therapeutic as well. Another paper came up about therapeutic bronchoscopy for malignant central airway obstruction, and there's the acquired data as well that showed that patients, even though they present a terminal stage of lung cancer, when you do some interventions like simply lasering a tumor and putting a stent, they improve their dyspnea score and they'll be able to tolerate their chemo and radiation better. Diagnostic-wise, and how do we come into the lung cancer screening? Staging, EBA staging is a major part. We have the ACCP guideline about the invasive mediastinal staging of lung cancer, and then we have the ESTS guidelines, which I like more. If the tumor is central tumor or more than 3 centimeters, we do the EBA staging regardless your BET is positive or not. We don't like to understage patients, so we always very thorough in our examination and staging before we send it to the surgeon. There's navigation bronchoscopy with the radial ultrasound for diagnosis of pulmonary nodules. A recent study came and showed the diagnostic yield of about 80 to 85% for pulmonary nodules, so definitely something promising. And use of the navigational system for placement of fiducial marker as well by bronchoscopy, so the surgeon can go in and take the tumor. These are just simple examples of the role of interventional pulmonology, and it's a separate talk, but we're not going to say more. Thank you for your attention, and if anybody has any questions. Okay.
So, you know, I mean, there's a lot of science behind lung cancer screening and that it's a good thing and you're going to pick up early stage lung cancer, but I think it was the American Academy of Family Physicians, which is this huge medical organization, came out just a couple of years ago, and they said that they didn't recommend lung cancer screening.
Right.
And they weren't convinced it was cost effective.
Right.
I mean, how do we compete against that sort of sentiment? I mean, I agree the science is there. What are the strategies to educate people so that they understand that there's...
So it's a good point, and I think part of it is basically to reach out to these providers and patients and do all these community programs, community outreach programs, provider educators about the lung cancer screening and how it is cost effective. And even though this association have actually, the American Academy of Family Physicians have not recommended that, a lot of the patients, they hear about it. They hear about it from the news, they hear about it from these billboards somewhere, they hear about it from their friends, and they come and ask for it. Because no one wants to be a smoker knowing that he's a high risk for cancer and not do anything about it. So I agree with you. I think it was about 3 years ago, if I'm not mistaken. Yeah. Just after the National Lung Screening Trial. But then the cost effectiveness trial, a lot of these papers as well that came and showed it's cost effective argues against it. But I agree, I think it all depends on how we advertise for it and how we reach to these providers and people in the community.
I mean, it's still a pretty low percentage of people that can be screened are actually being screened. Isn't it like 3% or 4% of the people that are eligible to be screened are actually screened?
Right. So with the way we designed it in our lung cancer screening is a little bit different. So we have a different form where we divide these patients into 3 groups. So group 1 is which fits the ACCP guideline, which is 55 to 74. And these patients definitely they qualify for low-dose CT scan. And then group 3, they young, very minimal smoking history of any, and these are out of the picture. And then group 2, where it comes, most of these patients fits, where you don't quite meet the group 1, so you're a smoker, but maybe you're 50, or you're a smoker, but you're at 25 pack per year. And in these patients, we tell them, look, the guidelines does not support to do the screening, but if you do have a positive family history, if you do have an occupational exposure, we think we should do it. And that basically goes to group 2.
Then what about reimbursement? Do the patients have to pay out of pocket for
No,
that?
no. We find a way. Yeah.
Okay.
Yeah. We did not have a problem with insurance so far for this group of patients because we're not addressing this under lung cancer screening. Yes, it's in our data, it's like group 2 lung cancer screening, but these patients came to us because they have some sort of symptoms, pulmonary symptoms. So that's how we catch it basically. Or they refer to us from their primary because of pulmonary symptoms. So that's how we catch it. So this is actually a big group of patients right there. Yeah. Thank you.
Very much.
Thank you.